our first speaker is, Ron Krueger, and I always really look forward to Ron's talks because of his expertise. He really gets access to a lot of the advanced technologies that are coming down the pipeline, and I'm sure we're going to see some really cool stuff. That hopefully will be coming here in the near future. So without much further ado, Ron Krueger with current and future trends in presbyopia correction.
So my initial talk to start things off is going to be on current and future trends in presbyopia correction. And this is really a section on advanced IOL technologies, but it really is a session on presbyopia overall. And a big part of that's IOLs, but there are other technologies which you will see as we go through this, this presentation. Just as a disclosure, I am a consultant with Alcon, an investor in RxSight, and an investor in Smart IOL. So I'll start off with this initial slide that said, did Moses have presbyopia? And in the scriptures, it says in Deuteronomy that Moses was 120 years old when he died, yet his eyesight was clear and he was as strong as ever. So whether he has presbyopia or not, we don't know, but his vision was quite clear. And understanding that both presbyopia and cataracts are number 1 and 2 in terms of eye disorders of aging, we could presume that he must have had early cataracts, but yet they weren't really bad. So it's sort of a little bit of a mystery. Usually that's an issue by the time you're 120 years old. It's mainly due to the age-related stiffening of the lens and sclera for presbyopia. So how do we currently handle presbyopia, at least surgically? Obviously, the things in white are how we're doing things with spectacles and contact lenses, but surgically, we either do a monovision correction, which can be done in an IOL or LASIK, multifocal correction, which can be done in IOLs or in some cases LASIK internationally, or in an accommodating or movement-based IOL. And I reduced that to the 3 M's of monovision, multifocality, and movement as a way to get that extra power for near vision. So I'll just start by saying, number one of the big things that predicate the type of procedures that we consider has to do a little bit with the age-related lens dysfunction. And that's just to say that there's a dysfunctional lens syndrome scenario where we can grade that in stages, where early presbyopia is at stage 1 of 40 to 50 years old. It's when the lens of your eye begins to lose some flexibility. It's the reason a lot of people start using reading glasses at this time. And there really isn't early cataracts at this point, so it's still very reasonable to do a laser vision correction type procedure with monovision, or in some cases maybe consider a refractive lens exchange for high levels of ametropia with either multifocal lens or monovision scenario. Stage 2 is presbyopia with early light scatter, more like 50 to 60 years old. You get a little bit of the optics beginning to degrade, image quality begins to diminish slightly, progressive yellowing and light scatter might occur, and you might consider again laser vision correction with monovision in these cases, but more likely to start thinking about a refractive lens exchange with either a multifocal type of lens design or a monovision scenario, or maybe even a movement-based IOL. And then finally we get to stage 3, which is greater than 60 years old. You pretty much have some light scatter and early cataract at that time. There's more yellowing overall of the lens and the scatter as well. And it might even affect the patient who has LASIK in terms of contrast and some of the quality. So it's going to be more likely that you do cataract surgery or refractive lens exchange with a multifocal or monovision scenario or movement-based lens. And maybe you'd still consider monovision laser vision correction in some scenarios. So that's really the number 1 consideration of the age-related reasons why we pursue one versus another type. But then there's also lifestyle preferences. And I like to use this example of 3 personalities that might be quite different in the way they view things. So we have the night driver, or so he says, who's very active at night and has a large pupil size. We've got the chemistry professor, where most of his work is in the intermediate range. And then we have the fashion designer, who is an active woman who wants good near vision and to be glasses free. So what we might consider for the night driver is pseudophakic or laser vision correction monovision, because he can wear glasses whenever he wants and he has no compromise in terms of glare, halos, or other dysphotopic phenomena from the lens that might be placed in his eye. The nutty professor might be looking for an extended depth of focus lens where he gets good vision at both distance and near, and helps him with some of his work that's in the mid-range area, kind of not so much really up close, but more mid-range where it's functional for his lab work. And then you've got the fashion designer who really wants to have some kind of a multifocal lens design, because she really wants it all. She wants the distance, she wants the mid-range, she wants the near, and a lot of those lenses will give her that flexibility so that she doesn't wear any glasses at all. Now, what happens if you mix them up and you happen to pick the wrong type of solution for that particular patient? Well, in the case of the night driver, he's going to have unwanted glare and halos, and it's going to make his life miserable. The chemistry professor is going to complain because he can't see working up close at his lab to do most of his work if he has the wrong lens. And of course, the fashion designer might complain that I can't see well up close without glasses, and glasses is a no-no for her. So it's very, very important to understand lifestyle, and questionnaires can be helpful for that. And the number three, I kind of talk about a little bit of maybe this trend of simplicity versus complexity. As we offer more complex solutions, we can drill down on just mechanisms that work better. But simplicity is always a good thing when considering surgical corrections. And ultimately, the question is, what's going to provide the greatest satisfaction and the lowest risk of dissatisfaction to your patient? So from there, I'm going to kind of move a little bit more into future. This is kind of a little the current. More of the future has to do with considering some of these things of simplicity, speed, and safety versus complexity, quality, and personalization. And I'm going to walk through that of drops to lasers to passive implants to new energy sources, and even to active implants. Eye drops for presbyopia correction have sort of hit the market with some attention because it seems to be a very easy solution if it can really work. And the pharmacologically induced pinhole effect seems to be one of the biggest ways. However, there's a Novartis product that is looking to place drops that decreases lens stiffness. And then nanodrops has been popularized a little bit and is still being investigated to change the refractive index that might help patients overall. So looking at miotic drops that really dominate the pharmacologic pathway, you can see a number of companies have a type of a single agent miotic that can be used in low concentrations tolerably. This one company here, Visus, does a combined mechanism using both a carbachol and a brimonidine, and that's the brimacol that has some enhanced efficacy. But basically, the miotic drops increase the depth of field by the pinhole effect. They're not without their side effects because you can get headaches and brow aches, and that's why we tend to use low concentrations. And the single agent miotics may have more of an issue with some of the side effects than the combination drops. And so combinations may be things of the future. Here again is just showing the prolonged duration that's coming by one of the combination drugs using brimonidine as well as a carbachol that seems to give enhanced effect. Lens softening with the EV06 is something that Novartis has been pursuing. It's actually a lipofulvic acid choline ester, which helps to break disulfide bonds in the lens. And in some early clinical trials, you can see from pre-op what the best corrected near vision is to the best corrected shift to better vision post-op after 90 days, showing that there's some promise, but we still need to see further results with that in the future. And then finally, refractive index change is the concept of using eye drops composed of synthetic nanoparticles that can be instilled into the corneal epithelium to modify the local refractive index and induce a temporary change in the pathway of light in a controllable fashion. So temporary refractive surgery, kind of like a refractive Botox. The concept is that you can measure this, and you can do this yourself. You can do this at home. You can measure your refraction with a smartphone. Technologies now exist that will give you a refractive error. You can then have a little handheld laser that creates an optical pattern. It's a painless superficial laser etching according to the correction that's needed. It's only in the epithelium of the cornea, so it's not a permanent etching. And so if there's an error or something, it can easily just not instill the drops, but it does allow for little craters for the nano drops to then infiltrate and populate in a certain refractive pattern that might ultimately give the desired correction. Here shows a little bit of a scanning electron microscopy of these nanoparticles. They're tiny hyper-refractive balls, 20 to 70 nanometers in diameter, and you can see where they tend to fill into the stromal crevices in a specific pattern. Some of the early outcomes, and this is not in patients, but just in cadaver eyes, which show that you can instill the drops. It does not change the keratometry at all because there's no curvature change, but the refractive index can get 2.75 diopters of plus power for reading if you wanted to do that in one particular eye. If you're going out in the evening and you want to give temporary monovision, you could potentially do that. Let's go on to presbyopic laser vision correction. That's something that's going to continue. LASIK and SMILE blended vision, maybe things that more of the future. Refractive index changed with some different company products. And then, of course, the idea of putting tissue implantation like a inlay, but not a synthetic inlay, actually using human tissue, which is maybe more something for the future. Lyric is a procedure that is being investigated. Scott McRae has been involved very much with this, but it's the idea of using sub-threshold femtosecond lasers, which can make small refractive index changes in the cornea and give some duration of effect of change in refractive error for near correction or presbyopia correction. There's a reduced fear because there's no real incisions or flaps, less keratocyte death, less risk of dry eye, ectasia, and some otherwise good superior quality. Blended depth of focus monovision is certainly popular, and that can be done with laser vision correction techniques. Just enhancing the overall depth of focus is a great way of doing that, and trying to make it more of a blended vision between the two eyes and monovision is an acceptable way. And then finally, Allotex is a commercial entity that's looking at implanting tissue for surgeon modification of ultimate shape. It can be used for hyperopia, but also with a very small 1 to 2 millimeter lenticule can correct presbyopia, and you can sterilize the tissue so that there's no chance for rejection or infection. And then finally, in the last couple categories here, presbyopic extended depth of focus IOLs are really exploding the market. We sort of have looked at EDOFs and trifocals as being sort of a mainstay of how IOLs are doing it today, and we're going to see more of that as we go to the future. Even the concept of an extended depth of focus phakic IOL that we can then implant, and it might be easier to remove if there was some dissatisfaction there, and then light or laser adjustable IOLs can also be entertained. With the EDOF lenses, they now expand into a category of multiple subcategories. There is a diffraction-based EDOF lenses, such as been initially represented by the Symphony lens. The diffraction ones, there's a refractive ones. The new Vivity lens by Alcon is one particular model of that. And then there's even the pinhole concept, which is rather robust. It has many advantages, maybe less glare and halos. And here you can see even just some of the overall comparisons of trifocal lenses, extended depth of diffractive lenses, and the pinhole lens, where you can see there's really good quality in each of them, especially the pinhole lens. So we may see more of that in the future. And you can get a good diopter and a half of refractive effect with pinhole lenses. A phakic or piggyback presbyopic IOL is certainly something we may see in the future. ICL is now about 20% of vision correction in China, which is quite amazing that there's such implementation of that. And it can be done as a very quick procedure because the Chinese have made that very adaptable. Having an extended depth of focus ICL with a broad depth of focus overall allows for further reading capabilities, and it's easy reversible as you can just remove that ICL, much easier than removing a lens implant. There's different models that may even have multiple ads. This is a trifocal one, an IPCL that's also been popularized and is early available in Europe. Light and laser adjustable IOLs with adjustable blended vision is a way that you can kind of control this to titrate it for a patient where you might have a more negative spherical aberration, extended depth of focus, and a non-dominant eye, still allowing for binocular summation and giving a good range that can all be adjustable after an IOL is implanted. So it gives us some good flexibility. And then final category is that of presbyopic pseudo-accommodation restoration, trying to really mimic that, that mechanism of accommodation as much as possible to really try to get the maximum restoration. And that's based on pupil movement, electro-optical IOLs, biomimetric accommodating IOLs, softening of the sclerotic lens and sclera, and then even remote reflective IOL technology. So just looking at the first thing, the autofocal movement-based pupil size detection of the Alenza lens is something where it detects what your pupil is. When you're reading up close, your pupil gets a little smaller. It'll actually electro-optically change the overall power of the lens with a chargeable battery that's within the lens itself to give you the near. The patient really doesn't need to do much, but just take a look and have that pupil respond in a way. And then there's this rechargeable power cells that when you're sleeping at night, you can recharge it and continue to use it. So it's using its power, not from so much from the accommodative mechanism of zonules, but from the actual elements in the lens. Lens curvature changing IOLs, such as this, is showing that within a flexible bag and multiple lens elements, you can see a fluid-filled optical element that changes with accommodation to give sufficient power. And this is over a very broad range of good optical quality in comparison to what we see here in the blue line of a PanOptix lens that gives you distance, mid-range, and near. You can get even a much more broader modulation transfer function response because of the movability of this to whatever desirable range that you need. And this really goes along with the concept of movable IOLs. The single optic movable lenses have really very limited accommodative capability because there's not that much movement in the residual capsular bag, and there may be scarring as time goes on. Some of the dual optics lenses have been popularized for greater range, but may also lose some effect. And if we can see more change in lens surface curvature with future accommodating type IOLs, we can get much broader range. And if we can avoid some of the scar tissue, we may get more successes in the future. With that, I wanted to kind of show this brief video of a new technology, new energy source to ophthalmology, which is selective shockwave therapy. And this selective shockwave therapy can be used for multiple treatments, but you can apply this very localized micro shock waves to the sclera and to the zonule and to the lens in order to soften those areas to then restore some of the otherwise lost areas. And you can use this for glaucoma and other reasons too. But this is new technology we may see in the future that could change the way we do things with presbyopia correction. And then finally, that of the smart IOL, which is super magnification and remote reflective technology. It's the concept of a multiple element IOL that has coatings within the IOL made of different semiconductor materials with nanoparticles that can be tunable, that you can turn them on and off in terms of their reflectivity. You can have an external control of the focus, so you can remotely activate the coatings to be reflective using a smartphone. So you can turn on a coating. It allows the path length to increase, and that would ultimately change the power focus based on the shortening or lengthening of the path length to allow for different refractive corrections. And you can even add an additional element of a non-refracting material that can also be tuned on that might help with magnification. So somebody with age-related macular degeneration might be able to get a larger image by just tuning it into their cell phone. And as it is now, about 77% of Americans and about half of the world's population have smartphones. So this is the kind of things that we'll see more of as technology is adapted to patients in the future. So in the future, as a summary, drops are going to provide the least invasive solution for presbyopia in the future. We're going to continue to see work in this area. Laser vision correction with blended monovision will still remain as an option, especially for lower age presbyopes. Tissue implantation will replace synthetic inlays because of the greater compatibility. Extended focus IOL solutions are going to have multiple expanded options. We've seen that explode in the last year or two with a whole new concepts for extended depth of focus, which I think Damien's going to talk about in the next talk a little bit. Combination restoration is really the next frontier as much as we can tackle that. And smartphone remote access is going to bring back control to the patient in the future. And so when it comes to simplicity versus complexity, we're going to have to judge for ourselves what really works the best for patients. And this is the late George Waring III, back when we were doing debates with the ISRS, showing him in rare form at that moment. And I thank you all for your attention and leave it open to any questions that you might have.
Great. Thank you, Ron. So just, one quick question for me. So in the US, we tend to be pretty conservative about refractive lens exchange compared to other parts of the world. Do you see that changing as more of these technologies become available so that, people in their 40s and 50s, are taking advantage of it and don't have to wait till they get cataracts?
Yeah, I think a lot of the explanation for that might have been that some of the lens designs that we had in the US were not as robust as the rest of the world because the FDA was slowing us down a little bit at introducing those. But we're seeing more and more of those lens designs come. It's a viable option for people to consider with different multifocals and EDOF lenses. But there still is a little bit of a love affair with laser vision correction in the US, even in some older patients. And so it just has to do with trends. We'll see what happens as the future goes on, but it's still viable for laser vision correction, even for 50-plus-year-old patients, even some 60-year-old patients may want to do it for smaller errors.
Okay.